Hello, I'm Dr. Marla Shapiro, and I'm a past president of the Menopause Society. And today I'm thrilled to be joined by Dr. Stephen Goldstein. We're going to be talking about recognizing and managing irregular menstrual bleeding during the menopause transition. And for so many women whose cycles go all over the map during that period of time, it's really a great topic. So first, let's introduce our guests. This is Dr. Steve Goldstein. He's professor of obstetrics and gynecology at the New York University Grossman School of Medicine in New York City. He too is a past president of the Menopause Society, the International Menopause Society, and the American Institute for Ultrasound in Medicine. So hello, and thank you for joining us today.
Well, Marla, thank you for having me. This is a topic near and dear to my heart. I think the first thing that women need to understand, in their minds, all the blood that comes out of their vagina is their period. But to me,
Right.
menses is a bleed preceded 2 weeks before by ovulation. And
Okay.
so perimenopause should be thought of as the mirror image of adolescence. It's the coming off of the reproductive years, just the way adolescence is the coming on. So during the reproductive years, women often ovulate 13 lunar months in a calendar year. Two
Right.
weeks after ovulation, they will get a menses. As they become perimenopausal, ovulation becomes less common and sometimes absent, but they still make estrogen. And if the estrogen levels fluctuate, it can destabilize the lining of the uterus and they bleed. To them, it's a period, but it's irregular bleeding. And so the most important thing for us as healthcare providers, when a woman who's perimenopausal comes in with such irregular bleeding, we have to establish, is there an anatomic cause or is this a hormone imbalance?
So
Hormone
that's from
imbalance.
your point of view. But as a
Right.
woman, if I'm sitting here and I'm a woman and I'm getting these irregular cycles, firstly, what's a red flag for me as a woman in terms of, oh, this is something that I should really go in and see my healthcare practitioner? What are those signs that are, oh, this is normal, this is, I'm sort of approaching menopause, so I expect irregular cycles versus I have a problem.
So the hallmark of normal cycles is their regularity, their predictability. The hallmark of cycles that had no ovulation, anovulatory, and from the Greek without, is all over the map. And I tease and sometimes say, no one ever got a biopsy or a D&C or hysterectomy for bleeding less. So
Mhm.
if you start to space out your bleeds in the perimenopause, that's a good thing. But the
Okay.
same physiology of not ovulating can cause people to bleed more often or more heavy. And those are people who need to be evaluated to be sure there's no anatomic abnormality and not just the hormonal changes of
So you mean
perimenopause.
something happening within my uterus as a woman? There's some other cause.
A polyp, a fibroid, a precancer, rarely a cancer, some sort of anatomic structural problem, as opposed to irregular hormone production causing the bleeding, which
Right.
can either be reassured and left alone or fixed hormonally.
Right. So if I'm bleeding every 2 weeks, that's not something that I should ignore then.
Correct. If you're bleeding irregularly and more often or heavier than it should be, then you need to consult your healthcare provider. If it simply starts to space out as you get closer to menopause, that's much more understandable.
Okay. So if I, as a woman, now identify myself as bleeding all over the map and I'm bleeding close, far, close, it's making me, not understand what's going on. And I come to see someone like you. What can I expect will happen in terms of evaluating whether or not this is just like hormone storm and I'm doing my regular change into menopause, or
So
is there something else?
we're kind of in a flux. For many, many years, practitioners did a sampling or a biopsy.
Right.
And what we've come to realize is that a blind biopsy like that can be fraught with error if the problem doesn't occupy most of the uterine cavity. So increasingly, people are using vaginal sonograms. And if you don't see what you need to see well enough, what some people call a water sonogram or a saline infusion sonohysterography, they're called medically. In other words, we can do ultrasound and a subset of ultrasound to less invasively tell what's going on inside the uterus with more accuracy. Then if somebody has something like a polyp or a fibroid causing the bleeding, you can deal with it anatomically. If the uterus is clean and it's all hormonal, then no further invasive procedures, biopsies, D&Cs, or anything would be necessary.
So that's reassuring. So let's say I've come in and we've taken what you call the anatomical, you need to fix it, you need to investigate, you need to do more off the table. And this is, is this something I just need put up with? Are there strategies to treat the irregular bleeding in this menopausal transition?
Right. The problem is irregular hormone production from the ovary. So the ideal treatment for the perimenopausal woman whose bleeding is hormonal, if she has no contraindications, the word we use, would actually be ultra low dose birth control pills.
Right.
Now, that's a whole nother discussion because that has a lot of baggage associated with it, which it really doesn't deserve. If people are healthy, they've had some children, they're non-smokers, they have normal blood pressure, they exercise, they're not obese, they're not diabetic. The use of hormonal cycle control is what I like to call them, will turn off the ovarian function whose erratic production is what's causing the problem and substitutes a very stable amount of estrogen and progesterone all month long to solve the bleeding problem.
It also offers something else that women forget about as they're reaching sort of their menopausal years, is that pregnancy isn't off the table.
And it is prescribed as a contraceptive, and the
Yes.
societies will tell us, whether it's Canadian or American, any woman who's still getting periods or bleeding needs to think about contraception. So when I prescribe this, I'm prescribing it as a contraceptive, but my main goal in a 49, 50-year-old, 47-year-old with this kind of bleeding is hormonal cycle control. But you're absolutely right. It gives contraception at the same time.
So many women who are sitting with this irregular bleeding also hear about the use of, other than a birth control pill, something like an IUD. Can you address that? Because that's out there. And what does that mean?
There are two types of IUDs. There's a hormone-producing IUD and then ones that aren't. They're excellent for contraception. The hormone-producing IUD is really helpful for people that have heavy bleeding. Heavy bleeding, heavy menstrual bleeding, often still fairly regular. It will cut down on that significantly. In some women, it will result in no more bleeding, but in other women, it can result in some fairly irregular, low level of bleeding. So if you really want bleeding control, the other thing that we haven't touched on is that if people do go on these low-dose birth control pills, there are some psychosocial symptoms of perimenopause: free-floating anxiety, mood swings, increasing PMS, memory changes, inability to concentrate, sleep disturbances. Some of these things are caused by this hormonal irregularity. And by turning off the ovarian cycle and substituting that small amount of estrogen and progesterone all month long, sometimes there's tremendous improvement in some of those symptoms, which a hormonal IUD is not going to do.
So before I let you go, two important questions that women want to know. How long can this last? And I leave it to you to try and give a simple answer to that. And if I do go on a low dose birth control pill, how am I going to know when I should get off the low dose birth control?
Well, the average perimenopause lasts about 4 years. The average menopause is 51.4. So you do the math, 47. But I've seen it be a decade, and this is totally variable, just the way women's height is totally variable. You could be 4'10", you could be 6'2". Most women are in the middle. In terms of if you do go on hormonal cycle control, i.e. low-dose pills, how do we tell if you're menopausal? Well, realize I'm giving you those pills to turn off ovarian function. If we define menopause as no more ovarian function, then I no longer need to give you those pills. But how do I know that? If I measure blood levels, I'm simply measuring what you took this morning or last night. So you need to be off for a period of time, probably at least 7. I take 14 days off, and then I can measure sex steroids and tell if the ovary is making its own estrogen or not. It's interesting, in the textbook we wrote on perimenopausal gynecology, the chapter on birth control pills written by a woman, she advocated keeping everybody on till 55 because she said by 95% of women are menopausal. I've never bought into that because I think you have to do this on a case-by-case basis. If a
Right.
woman was having symptoms, if she was having irregular bleeding, a lot of these patients feel great. They don't want to come off. And if they're healthy, I'll leave them on longer. If
Mhm.
somebody's pre-diabetic, if somebody's obese, if somebody seems to have what we call comorbidities, I may not want to keep her on much past 51. I may want to try and see, is she menopausal or not? So I think you need to do this on a case-by-case basis, depending on the individual. There's no
Yeah.
number, magic number.
Well, thank you so much for joining us and helping with this very confusing period of time for women and trying to give us some guidelines and some help as to when to seek, treatment and the fact that there is available treatment. Thank you so much for being with us today.
Thank you, Marla, for doing this and helping all of these patients.
Bye.